Okay, it is 4 o'clock. We are going to go ahead and get started here. Appreciate everybody coming to the regular monthly meeting of the Indian River County Hospital District. So, Pastor Moore, for the invocation.
Good evening. Let us pray. Heavenly Father, we come to you today in prayer and supplication, asking for your divine guidance, your divine wisdom, and your divine support as we begin this important meeting. Help us to engage in meaningful discussions throughout the course of this meeting today as we grow closer as leaders to lead this community in these trying times. Father, I pray that you would help us to nurture the bonds of community so that the decisions that are made today by this board will result in bringing our residents one step closer to being on one accord in all manners of healthcare for this county. Father, we lift up prayers and support for those who have suffered through this tragic storm that we all have endured through. God, we pray for those who have lost lives, those who have lost property, those who have just still traumatized as a result of what has taken place on this past week. Father, I pray, God, that this was an indication and use it as a opportunity for us to come together as a community, to grow together, to live together, and to serve, and to be on one accord in all things. Father, I ask blessings upon this committee and all of the decisions that will be made on today. I thank you, God, for each and every heart and every voice that will be heard on today. These things we pray in your darling Son, Jesus' name. Amen.
Thank you.
Thank you, Joe.
Yes.
Pledge of allegiance.
United States of America, and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you.
Thank you. Can I hear a motion for approval of the first budget hearing meeting minutes dated September 5th, the chairman's meeting minutes dated September 18th, the final budget hearing meeting minutes dated September 19th, the regular monthly meeting minutes dated September 19th, and an October disbursement of
$1,493,029.93.
So moved. Second.
all in favor?
Aye.
Thank you. I just want to say, last week was a very tough week, and we saw more devastation in this county than we've seen since Francis and Jean. And not only our county, but to the south of us. I was just telling somebody here that I talked to a St. Lucie sheriff's gentleman the other day, and he said regardless of what they're reporting on the news, there's at least 60 lives lost in Spanish Lakes. And that doesn't account for the ones that they haven't found yet. Okay, so, and down where in South County where I am, the devastation is unbelievable. People lost everything. I want to thank the trustees for approving funding to be able to support people who have been through that with prescriptions. We don't think about those things, that they lost prescriptions, that without power, the insulin goes bad, and we need to support them with that. I want to thank the mental health people in town here and Wes for giving free counseling to people that need it. It's very, very important, and we will support that as well. And also emergency meals, and Publix has stepped up big time to help those people. So let's just keep that all in mind, and thank you, trustees, for supporting that with us. We have Dr. Rothman and the A-team here tonight. Dr. Rothman has another meeting that he has to be at, and so he needs to leave around 4:30. So let's just keep that in mind with what we're talking. He's here for the annual report to give to us. So, Dr. Rothman.
Thank you so much for having me tonight. Can you guys hear me okay?
You need to talk loud.
Yeah, I have a tendency to elude the microphone. Is that a little bit better?
You're too tall, Dr.
So thank you to the district for your support of the hospital. We're going to talk a little bit about our annual performance in 2023 and review our annual report. Prior to doing so, we've had some questions about the state of the hospital following the storm last week. The team did yeoman's work as it pertains to maintaining services, healthcare services for the county. Our inpatient psych facility continued to run and accepted patients throughout the storm. Our generator at the psych facility did catch on fire, and we were able to source another generator to keep the facility running. We did lose one air handler. That, for those of you that are not aware, that's the way we condition our air in our buildings. Our team was able to also bring another generator in and use 2 out of our 3 air handlers to keep things running. We know that there was a lot of commentary around cancer services. We did lose power to all of our ambulatory sites from the secondary to the storm. On Saturday, we opened our cancer center, and we performed nearly 100 radiation therapies, and our nurses and our caregivers came in to support all of the cancer patients that needed chemotherapy over the weekend. And so thank you to everyone behind me who helped make that happen. With that, we've prepared an annual report that all of you have seen. We'll be summarizing the year 2023. We'll discuss the scope of healthcare services, description of our capital spending, our annual goals, and we'll summarize things with some final points on where we see the direction of healthcare here in Indian River County, both locally and then also comment on nationally. So with that scope of healthcare services, in 2023, Indian River Hospital performed more than 230,000 outpatient visits, nearly 55,000 emergency department visits, and almost 25,000 admissions. We performed over 15,000 surgeries and delivered more than 800 babies. As many of you know, Indian River Hospital is the only hospital delivering babies in Indian River County today. We also maintained all of our services from 2022 and expanded on others. There's been some questions about head and neck surgery and what that is, so I wanted to comment on that. For those of you that are not aware, Dr. Brian Berkey, the former president of the Head and Neck Society, is here at Cleveland Clinic Indian River Hospital. We have amongst the most comprehensive head and neck program between Orlando and Miami. In addition to that, we continue to support advanced oncology services. In 2023, we saw our number of oncologists double, and our number of radiation oncologists continued to grow. Thoracic surgery, surgical breast oncology, obstetrics, gynecology, specialty orthopedics are all services that we continue to offer. In addition to that, there is only a single thrombectomy-capable stroke center in Indian River County. What that means is we have the ability to remove clot from patients' brains after a stroke. Many facilities across Florida only administer medication. We're able to go in and take the clot out. Finally, heart and vascular services continue to grow here in Indian River County. For those of you that are not aware, we now perform transaortic valve replacements, minimally invasive mitral valve clippings, which are procedures that otherwise would have been done under anesthesia in an open heart fashion. Those procedures are all done in a minimally invasive way today. In fact, in 2023, we surpassed 500 transaortic valve replacements. In addition to that, we continue to grow our services that around our community commitment. We talked a little bit about inpatient psych and women's health. I think it's important to call out that special partnership between the Indian River County Hospital District and Cleveland Clinic Indian River Hospital. It has allowed us to continue to expand services while the majority of hospital systems across the United States are shuttering them. As mentioned, we delivered more than 800 babies last year. And as some of you may know, we just announced a $7 million renovation of our labor and delivery unit that is currently underway. We also talked about inpatient psychiatry. Along with the partnership between Cecilia behind me and the Indian River Hospital District, we also expanded our psych services. And today, we have outpatient psychiatric treatment available for pediatrics. Not a small feat when you consider the state of healthcare today. In addition, there's an insatiable demand for diagnostic testing. Radiology services continue to be some of the most in-demand services across the United States. The reason that's important is there is not an infinite access to radiology services. Our teams continue to expand both our mammography, which we have now added to the both hospital side and outpatient side. We've added a third MRI to be able to perform specialty MRIs for patients who may have prostate cancer and breast cancer. This technology is not available anywhere else in Indian River County. As we think about that, what that translates into in 2023 in terms of our capital spend, when we exclude philanthropy, we spent a total of $22 million in capital. In fact, since the acquisition, the Cleveland Clinic has spent over $100 million, a total of $112 million in capital, excluding any philanthropic gifts. As we start to think about what that translates into, I think it's important for us also to mention how we're performing against our annual goals and benchmarks as it pertains to quality and outcomes. The Cleveland Clinic Indian River Hospital is a 4-star rated facility, meaning that when we review our facilities against benchmarks in the Center for Medicare and Medicaid Services, we are amongst the top performers. We are amongst the top hospital in the state of Florida. We are ranked in the state of Florida. If we reflect on that for a moment, we have a hospital in Indian River County that is ranked by U.S. News and World Reports. That doesn't come without challenges, and we continue to assess how we're performing based on our patient outcomes. Our outcomes are good. Mortality, as we view as what's observed to what's expected, any number less than 1 is considered good. Our target in 2023 was 0.76. I can tell all of you that the numbers we just saw yesterday are down to a 0.43. Meaning what we would when compared to a benchmark of a similar patient population, your chance of surviving hospitalization at Indian River Hospital is almost 2-fold better than any other hospital in the United States with a similar patient population. We know that we continue to be challenged by catheter-acquired urinary tract infections. That has to do with the Foley catheters that are placed in patients. That is a function of how many Foley catheters we put in. We have significantly decreased the number of Foley catheters that we place in patients. Therefore, even one catheter-associated infection is too many. Our nursing teams continue to engage and drive down the rate of catheter-associated infections. We know that our patient population is elderly. One of the challenges across the United States for elderly patients in the hospital is pressure ulcers. There's only one hospital in the Cleveland Clinic enterprise that has not seen a hospital-acquired pressure ulcer in over 3 years. That's the Indian River Hospital. So as we start to think about the outcomes of our patients, the outcomes are good. We know that operationally, there are opportunities as we look at how we provide better access to care. We fully recognize that care needs to be reimagined. And the way we deliver care today cannot be the way we deliver care tomorrow. It's not sustainable nationally, and it's not sustainable locally. So it shouldn't come as a surprise to many that in our statement of operations, that in 2023, Cleveland Clinic Indian River Hospital suffered a loss of more than $60 million. That operating loss is secondary to many things. However, those headwinds are similar to what's faced across the nation. As hospitals continue to shutter, despite the local operating loss, our hospital continues to expand its services. And expanding its services, not in areas that are financially accretive, but areas that the community needs. Mother-baby, psychiatry, and then other services for an aging population, cardiology. We mentioned a specialized MRI for prostates and mammography services. We know that also that Indian River Hospital continues to provide a large amount of indigent care. And as we discussed at the previous district meetings, the rise in unfunded care across the state of Florida is not unique to our hospital. Since the acquisition by Cleveland Clinic, Indian River Hospital has funded more than $60 million in charity care. In addition to that, our teams continue to look at ways that we can contribute both to our local FQHCs and partner with local foundations such as We Care. We know that there's an opportunity. There's an opportunity for us to start to think about how we articulate what we're saying today to the community. We know we can do better. We also know that we can provide a seamless experience for patients. The team behind me is committed to that. We don't expect it to happen overnight, but we expect that month over month we continue to see improvements, both in the experience of our patients accessing our care and the experience of our caregivers that are coming to work every day. For those of you that don't know this, we employ more than 2,500 people here in Indian River County. The school board employs about 2,400, Piper Aircraft, the largest private employer, about 1,400. So not only do we do more than 230,000 outpatient visits, 50,000 emergency department visits, we also are the largest employer. That doesn't come without a large obligation and commitment from all of us. We recognize where the opportunities are, and we appreciate the partnership and the feedback. And with that, I'll open it up for questions.
Questions for Dr. Rothman?
I'm just very impressed at what you've accomplished since you've come on board.
Thank you. I get to talk about it, they do it.
I know that feeling.
I have a question. I was talking to a resident today and happened to be in the legal field, and they said, "Are you nervous at all that Cleveland Clinic is going to pull out of here because of the losses?" And I said, "Absolutely not. I'm not nervous in one bit." And but I posed that to you.
Yeah, thank you for the question, and I think that apprehension is not just happening in Indian River County, it's happening across the country as hospitals are suffering these large losses. Indian River County, unique in the sense that we recently saw a hospital go bankrupt. We are committed to continuing not just to fulfill our obligation, but to expand on it and to look at how we commit to this community and provide better health care. We think these financial headwinds are transient and we will get through them. So we are committed to being here. As mentioned, we just invested in labor and delivery services. I didn't mention this, but I will. If it's not public, it will be now. We just announced a $15 million renovation of our emergency department. And so we are committed to be here. I think as important, we are committed to continuing to learning on what we do well and expanding on that, and where we have opportunity and taking advantage of that.
Thank you.
Yes, I have a question. Excellent presentation, Dr. Rothman. Two, can you explain a little bit more with the role of the Cleveland Foundation that I noticed that your chair is here, related to the emergency room and the funds that you were contributed to the maternal suites, the obstetric suites?
Absolutely, thank you. One of the things that we've continued is we do have a unique structure here within the Cleveland Clinic Indian River Hospital. We have a foundation that's local, that partners with the Cleveland Clinic, that continues to support these needs of the hospital. And through that, we're able to expand on services that we otherwise would not be able to expand upon, similar to the district that enables us to be able to expand on community services. I think for those listening and for the residents of the county, I don't know that there is a clear understanding and therefore an appreciation of both the work that happens on the foundation side. And if we reflect on that, many think that we take the money and I don't know where they think it goes, but I can tell you where it goes into mother baby units. It goes into bettering our emergency departments. Our work with the district, without the district, we would not be providing inpatient psych services. And what I can tell this group is, and for those listening, all of you have enabled something in this county that I don't think many counties are privy to today. As a matter of fact, I don't believe there's an inpatient psychiatric hospital in Martin, St. Lucie, or Brevard County. And so if we reflect on that, that's the work of this team, and similarly, our ability to expand services supported by the foundation. Thanks for the
So
question.
the expansion of the expansion of the emergency room is in part a Cleveland Clinic Foundation effort as well as the.
That's correct. That is correct.
I have a question. Even with, all the good work that you've accomplished over the last several years, what would you say now are your top 3 operational challenges?
Yeah, thanks for the question. I think we called out the first, which is access, and ensuring that all the patients have access to the services that we provide. There's the consequence of the shuttering of services is that we now become the central site for care. And our teams are working diligently to expand that access. We also need to ensure that we're the preferred hospital for physicians to deliver the care. And to do that, continuing to reimagine our relationships, both with the Cleveland Clinic physicians and those community physicians that are not part of the Cleveland Clinic. All of the physicians in Indian River County on our medical staff are part of Cleveland Clinic Indian River Hospital. And that's a commitment that our teams have really started to explore. And we've seen such an affinity for the hospital by the community physicians, and we hope that continues. Third and final is reimagining how we financially operate our hospitals. Joe Iannucci behind me, Gabe Brooks, and the team are committed to ensure that we have a sustainable care delivery model. Part of that sustainability means the way we deliver care has to look different. Indian River County houses the Center for Virtual Hospital Care for the entire Cleveland Clinic enterprise. We've actually created more than 30 jobs here in Indian River County, more than 100 jobs across the state of Florida relative to our hospital care at home program. Hospital care at home allows for us to hospitalize patients in their homes without the challenges of having to be admitted to a brick and mortar hospital. And so as we think about the operational challenges around access, engagement of all providers, and then thinking about how do we financially create a sustainable model for care for the future. Thanks for the question, Karen.
I have had a couple of conversations that I think have been inaccurate, and I've done my best in discussing. When people continue to suggest to me that doctors, that nurses, that staff are leaving in droves. I know that's not true. I've heard about, I know where we were at with traveling folk, through COVID and where we're at now, but in general terms, would you speak to that?
Absolutely. So it's partially true what you're hearing. There's a national trend for healthcare workers, both nurses and physicians, to leave the workforce. And again, we're not immune to that here at Cleveland Clinic Indian River Hospital. We have seen our attrition rates significantly slow, and our travelers, a number of travelers that we have, return to pre-pandemic levels. Linda Walton behind me is our chief nursing officer who's been instrumental in that work. We continue to see our attrition rates decline. That's a result of improved caregiver engagement. The best way that we tell our story is through the 2,500 people that come to work every day and care for our patients. Our caregiver engagement scores continue to increase, and Lorna, keep me honest, I believe are up now over 40% since 2022. On the physician side, the physician turnover has been high. That being said, we've begun to see that stabilize really over the last 12 months. Our number of oncology providers have doubled. Our number of general surgeons has increased. In fact, another general surgeon will be joining us next month. We continue to see physicians leaving the workforces for reasons that are outside of the control of the Cleveland Clinic, for personal reasons. Some want to live in different areas. Partnering with the municipalities locally to determine what can we do to make this a place where nurses want to live and can afford to live. Affordable housing is a challenge for our employees. And because of that, we have seen many leave the workplace.
Yeah.
Not just nurses, but physicians as well. Our number of primary care physicians has nearly doubled. Attrition in primary care has significantly decreased. As many are aware, we took on the radiology group as a result of external circumstances. And so over the last year, we have employed 14 radiologists. And because of that, we saw some headwinds in providing quick radiology reads. And many of you on this committee are aware of that. Again, those are transient problems. Attrition rates across the United States for healthcare workers on a 12-month basis is about 17.5%, give or take. We were well over 25%. We're now down to 20, and we're continuing to see that number increase or decrease towards the national benchmark. We suspect that next year when we come back to this team, we'll be reporting a much lower number.
Thank you.
Thank you, Michael.
Are you prepared for the next physician fee cut in 2025 that's going to occur reimbursement-wise? And I don't know because I haven't spoken, I don't hear anything about your United Healthcare that you were working on, and Medicare patients versus the Advantage Medicare. What kind of percentage is that for the hospital of regular Medicare and
Now
supplement?
the questions
versus-
get tough.
So there's
So
three.
just so I get that, I'll kind of go backwards, and then if I forget a question, just let me know, and I may ask Joe to step up. So as we think about, I'm prepared now to say that we have reached in principle an agreement with United Healthcare. Beyond the scope of this discussion is the details of that agreement, but I can say with a high degree of confidence that we have, in principle, reached an agreement with United Healthcare. As we think about the Medicare percentage here in Indian River County, Joe, 70%? Nick?
Yeah.
Medicare Advantage.
Yeah, Medicare
commercial.
Advantage is around 70% at Indian River. It's about 50-50 now, at the last time I looked at it, in terms of traditional Medicare versus Medicare Advantage.
Does the hospital do better with one versus another?
So traditional Medicare is a little bit easier. There's, I don't know that I want to get into all the functional differences that exist. There are challenges with Medicare Advantage around authorizations. In terms of the actual payment, it's very similar, but Medicare Advantage there's different rules that exist that they can propose on us that cause some delays in care, unfortunately.
I think as we look at if we look at a global level, on any given case, government reimbursement is less than commercial reimbursement for the most part. 70% of we get paid is government reimbursement.
I have a few comments. I'd like to actually record reflect that Barbara was the one that asked a difficult question this afternoon. I appreciate you and your engagement here. Over the summer, Dr. Rothman reached out to me, and we met. Since then, leading up to today, we've had an opportunity. I've had some questions, and he's addressed them. So I appreciate your interest in that. And you kind of undersold the stroke care. There's a safety element there that the public really should know. The medicinal treatment is far more risky than what you're doing in terms of conversion to a hemorrhagic stroke. So, for those in the public, that's really something for us to have here in terms of our capacity to treat and knowing that you're going to come out far better from that stroke treatment than the more traditional, what we think of it medicinally. Again, I appreciate the season we're moving into and working with you and the transparency and opportunity to collaborate. And I think your outreach into the community and trying to engage with independent doctors is important because that has been an area of discussion in the community. And I think that you're uniquely situated for Cleveland Clinic because of your relationships here. And I just want to continue to affirm that. And then I mentioned this yesterday, but I have a lot of people that come to me with various observations, and I try to, I don't want, because I'm one of 7, I have no authority to try to solve any problem. So I either suggest that they call the ombudsman's office or contact Frank. And what I'm hearing is, and this is maybe a training issue and a underutilization of a resource that you have, and that is the ombudsman that you do have. Usually the final conversation that results in a phone call or whatever, to me, is one that has not been fruitful. And I think an additional buffer for Cleveland Clinic in terms of your public relations might be that your folks are trained that when they get to that point, rather than that being the end point, they get a recommendation throughout the hospital to contact the ombudsman's office, because that ombudsman is probably going to be somebody better trained to de-escalate and to inform and take the time. Additionally, that's a data source for you, in terms of if you've got a hot spot that you're unaware of and your ombudsman's office starts getting those calls. And that'll just help you with your community engagement, I think, in the long run as well. So just a nickel's worth of advice, and I'm looking forward to continue to having conversations with you about some of the other topics we've talked about. Thank you.
Thank you so much, Paul, for those comments. And I think as we think about the ombudsman, there's a value proposition. It goes back to the initial comments and to your point, Paul, that there's an opportunity for us to articulate what we're doing well, what we have available, and what we're working on. And hearing that as we start to think about the ombudsman infrastructure that we do have, I think there's an opportunity for all of us to start getting that information out there and even training others to be ombudsmans for us. We just talked about the volume of patients we're seeing today. Certainly that same number of ombudsmen couldn't take care of that today. And I think Linda Walton and the team are here, our chief nursing officer, thinking about also how we train individuals on the floors. But I can bring something back to this committee at a future date on our ombudsman program. I think it'd be helpful to start getting that word out there.
With that, I think you're behind time, that you needed to leave.
Thank you.
But I'd like to thank you for everything that you're doing, and the whole team, though. You really have a spectacular team here, and I know they're all very committed to doing the best thing for our residents and our members. So we appreciate that. And we hope to continue this relationship that we've got.
Yeah, thank you for the support. Thank you, guys. Have a good night.
Thank you very much,
So-
all of you.
Thank you.
With that, we'll go to the district council report. Jennifer?
Thank you. It's been another busy month. As always, we continue to review your deadlines and deliverables due to the district under the lease with the Indian River Cleveland Clinic, and have responded to your questions as those arise. Under the leadership of our trustee Karen Deagle, we now have a fully executed contract to purchase a property to house a future women's sober living program. So we're really moving along with that. We are working, or have even as of this afternoon, ordered a survey and are working to confirm scheduling an inspection of the property. And so we'll be bringing you details on that as we get the results of our due diligence items there. I've also reached out to their council to try to coordinate a call to work through the items with regard to the land use restriction agreement. And I know we're still working to get a meeting with the county, I believe, on the zoning matters. So that's moving nicely. As you all know, we do have a lease now with VCOM, and I did get all of the parts and pieces from Cleveland Clinic on the waiver of the right of first refusal they hold on that parcel. We also have had a bit of time this past month we've spent on strategic planning efforts, and I continue to remain available to you if you need anything in that regard. I believe we're working to finalize the minutes and circulate them to you if you have not already received them. So those will be forthcoming. And we've also, of course, concluded our annual budget funding cycle, and now just keep receiving almost daily from Jenny the finalized agency funding agreements for our new fiscal year. And I think it was not last week, but the week before last, I attended the taxpayers luncheon where Mary Beth and Frank both spoke, and a number of you were also in attendance. So lots going on. Questions, anybody?
Busy. Okay, hearing no questions, we'll move on to the financial report. Michael?
Thank you. Fellow trustees, we're very fortunate that at the end of fiscal year 23-24, the financials show that the Indian River County Hospital District is in very good financial condition. Let's explore, as usual, the financials by reviewing the last 4 pages of the financial report that you received in your packet. And we'll start with, I'm not sure if it's the fourth from the end or the last, because I don't remember the framework, but let's go to the snapshot that Frank puts together, the financial snapshot, which again is through September 30th, and it focuses on the district's investment in cash holdings. The top section of that report shows that our net ad valorem tax receipts for last fiscal year totaled $12,946,443, and that's less commissions and uncollectibles. That amount is actually 102% of what we budgeted as tax revenue, and shows the district income was over budget by $258,383, and again, that was that back taxes that we'd received that's noted in that note. Section 2 of the snapshot just lists the update for our laddered U.S. Treasuries. They total $5,389,790. Section 3 shows our investments in the Florida Fixed Income Trust, that money market account, which total $5,014,655. And then that last section toward the bottom, section 4, I guess, of the snapshot shows the status of our local operating accounts at Seacoast, which we're holding $385,485 at the end of the fiscal year. Together, all those total $10,759,932 in our cash and investment holdings. If you flip now to the first page of the 3-page year-to-date expense versus approved budget, this obviously was the last monthly report for last fiscal year, so you can expect that total expenditures of the budget in this expense area, program area, would be 100%, and many are, or they're very close. If you scan down, as I always say, those first 2.5 pages, you'll see that we only have 5 agencies which exceeded 100% of the budgeted expense. They are Healthy Start Coalition, Senior Resource Association, Whole Family Health, Globe Check, and Sunshine Physical Therapy. And please ignore Healthy Start Coalition. There was an error that was made and has subsequently been corrected for the PEPW program, which brings that agency to exactly 100%. Those other 4 agencies all came to us during last fiscal year and asked for additional funding, which we approved. The total for all program expenses through September, through last fiscal year, was $16,077,602, which computes to 98.7% of the total program budget that we had approved for last fiscal year. The bottom part of that last page shows our administrative expenses. And as we've discussed in the past several months, some of these items are over budget, but there are no new surprises in the month of September. We can speak to those again if you have questions, but they've been covered. You'll see there that the total admin expenses for last year were $1,280,732, which is 109% of the budget that we'd approved. And then combined, administrative and program expenses totaled $17,358,333, and that's 99.4% of budget for 22-23. I think, I've got 1 year's experience here, but based on what I think I know, that's probably as close as we come to what you've actually budgeted. You've had you've had pretty good return, because I think there's been a larger number of programs that have underspent what was budgeted. But we were very tight here.
Closest to 10 years, I can tell you.
Oh, there you go.
There you go.
I knew that it was good, but I just point that out. And every year is going to be different. And there are always variables in every given.
Michael, it just goes to show how good you are.
Yeah.
That's right. That's right.
I'm just the mouthpiece, I keep saying. I will point the point of comparison for the end of fiscal year 22-23, our total expenses were only at 87.1, so we had a nice carryover. And there is some carryover from this year, not in abundance, but there's some there. And with that, Madam Chair, that concludes my report, but I'd be happy to answer any questions that the trustees might have.
Any questions for Michael?
Just one, Madam Chairman. I noted he said the ad valorem tax refunds were $12,946,000, but the budget was $12,600,000. Do you give the money back?
No.
You'll find some way to spend it?
It's some of that money that's tucked away in some of those,
It's earning money.
it's earning money for us, yeah. And that was a windfall. I mean, that 306,000 that dropped out of the sky was,
We weren't expecting.
no, I mean, and it hadn't seemed to have happened in a long time, if ever before, so. But we're in a good position. I will note, numbers are gonna change a bit when we look at our cash in investment, because we just spent $4 million. So we knew that, it's all planned for, budgeted for, but it's gonna shift. But that was intentional, we know what we were doing, we knew why we did it. And we'll have a whole new program at some point in time to start reporting about, more importantly, that's gonna impact this community in a very positive way.
Any other questions for Michael? Okay, moving on, the executive director report.
Thank you, Madam Chairman. I just have a few updates, and I'm going to ask Caitlin to walk through our dashboard. We're wrapping up strategic planning now. Our last meeting was October 2nd to further refine our 5-year goals. We added objectives, performance measures, and standards in compliance with state accountability standards and requirements for special districts that went into effect this year. A follow-up item on mental health court. The district convened all parties involved in the continuum of care for the IRC mental health court to discuss the mechanics of client flow and see if we could really get our arms around the distribution of funding and how the whole process works. Our next meeting is scheduled for October 22nd. I'll have an update following that. And last, the preventive care funding gap. So the district has been working with United Way, Community Foundation, and others to develop a joint funding solution. Meetings continue, and if you recall, this was for the preventive care funding that was cut to 3 very important programs that are provided by very critical agencies in our county that are going to focus, consistent with what I talked about Friday, consistent with what the district does, is focus on preventing conditions before they start, preventive care.
May I ask a question? The performance review that we went through, I know we turned that in, I'm going to say June, July.
June.
Do we know what happened to it? Did it go into a hole up in Tallahassee somewhere?
Well, one of the things we were very careful to do, and the whole team, Dawn reached out just to make sure, and I wanted confirmation in writing that they received the submission and marked that it was in on time. We have that document.
That's good.
So other than that, we have heard nothing.
Okay.
So we're glad we worked so hard on that. But well, maybe another couple of years, we will see.
Well, it was a good, regardless, it was a good thing
Indeed.
for us to do, too.
100%. So I'd like to ask Caitlin just walk us through her fantastic dashboard, if you would, please.
Okay, all right, I'll make this quick, but just a reminder, it is up on the website now, so if you guys ever want to look at it at any point, it's under the impact tab, healthcare needs in Indian River County. And you can make this full screen, so it's not too small. And I'm just gonna go over 2 of the pages, because most of this stuff has not really changed. We're not gonna update a lot of this data too frequently, because we don't have information. But fee-for-service agencies is gonna be one of the main ones that will update monthly. And so, since we wrapped up the fiscal year, this has the entirety of the whole year on it now. So you can see for total visits, we did almost 30,000, 29,000 visits, which is quite a lot. And so I have it broken down by the different services and then which agency were the visits. And then if you want to, you can also like narrow in on something if you have interest in that. Another thing that I did add, a lot of the agencies don't have multiple locations, but TCCH does. If you click on this little arrow, and then you can click on TCCH, it's gonna break it out by what location as well. So you can see what locations are getting the most amount of visits.
Caitlin, does it show somewhere how many individuals? I see the number of visits, but
I don't have that currently for like,
who's been touching?
yeah, I don't have currently how many unique patients per month. Yeah,
But we do know, Caitlin, share the statistic we talked about earlier. the
yeah, so on the
increase.
next page, we have, I have the total amount of applications that we received for the year. And then 4,012 is the amount of active patients that we currently have in our portal. And then the growth from the beginning of the fiscal year to now is 8.8% increase in the amount of patients that we've been seeing, or the amount of patients that are in our portal.
So call it around 9%. And if you remember, there's some parallel between this and the fact that our Medicaid redetermination that happened a year ago impacted 10,000 of our residents, children and adults.
Yeah, I do have that on this graph as well. You can see where it dropped off. And then right when it dropped off, we started increasing as well. So you can see it's kind of working together. Yeah, so pretty much those are the 2 pages that are going to be updated every month. And then going forward, I am working on going back to the past fiscal years, getting all those visits together so we can see what it's looked like over the past couple of years as well. So I do want to get that in.
So as we move other agencies to the fee-for-service, that will be updated as well with the number that we're
Yeah, I'll
showing.
be adding those in as well.
Correct, and Jenny's been working hard on doing that now, and that's, we're getting everyone on fee-for-service that we can. And it's a transition for them, but it's an important one.
Those that are not or can't, and we're wanting to track how many people we're providing, will there be another page where it shows
Yeah, so.
unduplicated clients or unique clients?
Yeah, we're gonna start getting all of those numbers from all of the agencies.
Yeah.
Some of them are gonna be a little more difficult just because they're unique, but we're gonna get as much data as we can, and then I can do different pages. I might end up just creating a different dashboard that's just gonna be agency-specific rather than all of this all together. But yeah, that and stuff like the mobile units, we wanna start tracking all of that, have a separate page just for mobile units, that sort of thing, too.
And that's obviously why I asked too. I mean, I'd like to have my first comeback when I get asked the question, who the heck are you guys and what are you doing? I want to start with, well, this past year, we've touched the lives of X number of people.
Yeah.
We've helped make them healthy, or got them healthy, or prevented them from being less healthy.
Yeah.
So that's exactly what, you know,
And
we're so much closer. That next step would be amazing.
And this is just visits, we really haven't, and what Caitlin's getting at is we've talked about, and the agencies are aware of this too, making sure that we have on a regular basis all the, you could use the term touch points or contacts, but really representative of the impact our district funding is making for the agencies and the community. In addition to that, we also, once we get this survey data, we'll be adding our annual survey data for those key metrics to this as well, and then other data points as they come in from the Fed and the state for comparison.
It's really good.
Really
you.
good. Very nice. So cool.
Thank you, Caitlin. That concludes my report. Thank you.
Okay, any other questions?
Well, you alluded to it. I was going to ask. I mean, Frank asked whether or not the trustees would support the contribution too, and you referenced it, so
We did.
was pleased for that as well. So wanted to note it.
Okay. Funded agencies, Cecilia.
Hi.
Hello.
Good evening, everyone. I have Kelly Williams with me. She was here last time. So she's a year into her position as the clinical manager for the outpatient program. So I'll let Kelly start with the intensive outpatient program.
All right. I have the 4 questions that you guys typically send, and so I just wanted to share some highlights of what we discovered over the past 6 months. One of the things that we realized that was not expected, and that also reinforced our strategy in programming, is recognizing that our intention in creating IOP was a very specific population of that intermediate care, right? So following discharge from hospitalization or as a step up from outpatient care. Very specific in what we were looking at. What we have realized because of the breadth of needs from our community, that we have been receiving referrals for people who are somewhat outside of that acuity level. So we have, for example, individuals who are maybe best suited for residential care, but they can't make placement yet, right? And so without our program or services, they might require additional hospitalization. So we have created opportunities to be able to serve individuals in that capacity. I have an example of a teenager who experienced many hospitalizations over a very short amount of period of time. It was recommended that he participate in the CAT team with New Horizons, but that they had a waiting list. And so we were able to individualize his treatment because of some of his intellectual needs. The group therapy dynamic was not appropriate for him, but that we developed an individualized plan to where he came in once a week for an hour, and that we were very focused on essentially applying our curriculum to what he needed and what he was able to do. So that's an example of that higher acuity. We also have an inundation of people who are calling, requesting traditional outpatient services. We know from talking to anybody that being able to get in with a provider is rather lengthy. And so we have been able to work with, in the past 6 months, being able to hire our full team, that we are able to open up some outpatient services. So when we compare the first 6 months of the year to the past 6 months, the most recent 6 months, we've increased our individual services 91% in being able to meet the needs. What is also an opportunity for us is that being able to provide those individuals therapy sessions, had they not received any services, they might be at risk for hospitalization. So we're able to mitigate that. We're also able to work with them that if their symptomology continues to increase, we're able to get them into the IOP program, right, to again mitigate that need for hospitalization. And so that's been a new finding for us that has been great to be able to see change in patients who are just a little bit outside. It's encouraged us to really expand what our reach is for patients. Yeah. Oh.
91% increases.
Yes. Part of that was in the first 6 months of this past fiscal year, we were down 2 therapists. And so by nature of being able to fulfill the completion of our team, that definitely opened up, opportunity of being able to provide those services. But it allowed us to fill their schedules quickly by meeting the needs of those patients.
Yeah, if you think about it, the community as a whole was so invested in finding more psychiatric providers. We did that, right? But then those patients didn't have a place to go for the outpatient therapy, which is normally a component of that, right? So going to all the meetings in the community, we realized, we kept hearing, they need an outpatient therapist, they need an outpatient therapist. So Kelly and her team stepped up and was able to provide that tweak early hours, afternoon hours for family. So it's really worked out great.
Right.
That's really neat that the collaboration is working.
It is.
Yeah.
Even one of the things, one of the secondary questions, what are some interesting findings with the changes in budget restrictions with the school district? I did some tracking of referrals. Last year, the first day of school to today, we received 0 referrals from the school district. This year, first day of school to today, we've received 7 referrals for services for children. And so that's a mixture of IOP services, maybe traditional outpatient. They're seeing, the needs of our community, and they're reaching out to help. So whether that's an outpatient provider who isn't able to provide the capacity of care that a patient needs, or, I don't have anybody to see this kid, is there anything that you can do to help? We've collaborated with Wes at the Mental Health Collaborative, definitely with Sarah Ainge from the school district, and a couple of other agencies. It is really nice to have that collaboration effort to make sure that all of our people are seen. Yeah.
A really good, interesting thing as well. So all the advertisement and stuff that we've been doing for the children for IOP this summer, Kelly experienced something with some of the school members. You wanna talk a little bit?
So during the summer, this has never happened. During the summer, we were able to provide IOP services to 4 school district employees, so adults who are seeking IOP services. So traditionally, our IOP program for adults is in the morning time, so 9 to 12. And so it was a really interesting experience to be able to have. And there's also kind of camaraderie and, support of adults who are like-minded, right, and who have a like life experience to be able to participate in group and being able to get their needs met for mental health care. I know that at least one of them joined IOP at the encouragement of her principal to say, during the summer, please take time for your mental health so that you're able to, return back to the classroom in a way that is benefiting yourself and the students that you work with. So one of the opportunities I think that we have is to consider what our programming times might look like. So right now, following discharge from IOP, we're able to offer a step down, so an outpatient group that meets once a week for up to 3 months or so as an additional layer of support for individuals who are finished. Being able to participate in our program for 6 to 8 weeks is a lot, right? They come to us for 9 hours a week for 6 to 8 weeks. And so dropping them off and saying, good luck, I hope that everything goes well in outpatient care is a shock to people. And the reason why we started it to begin with is because patients were asking for it. So we traditionally do it during the day. Well, if we find that there are a significant number of people who would benefit from an afternoon, that is definitely something that we are considering as an opportunity for growth in the future, is to be able to offer some of these services in the afternoon or evening to be able to provide a better catchment for people who work during the day.
That's great.
It's a big population, number one, but I was really pleased that 100% of the students involved in IOP maintained attendance or
Yes.
maintained participation with the school district.
Yes.
That's significant.
There were a couple of them that transitioned to virtual school by nature of, anxiety and different things like that. But you're right, being able to sustain their academic career, so to
3
speak.
sessions a week, 3 hours at a whack.
Correct.
I mean,
That's a lot.
it's great they're working with you and the students as well.
Absolutely.
Because that's an anomaly, but they're dealing with it.
Right. In the past, we have definitely worked with the school district when it comes to making sure that the students can leave. I can think of one school in particular, I think it's Charter High School, gets out a little later, or they have varying hours of being able to offer classes. And so in the past, they have been very great in working with us to ensure that their students have kind of that earlier schedule of the day, or that maybe one of their electives is on the days where they would leave, kind of early in order to be able to attend group. But it's been nice to be able to see that they're able to continue on. That's one of the challenges of the whole reason why we started to begin with, was missed school, obviously the increase of hospitalization. So it's been nice to find ways to be able to reduce that.
And had we not had you guys' funding 3.5 years ago and the support from other funders, we don't know if this program would be here today, right? And if so, what would it look like? It might just be outpatient. But it's been so effective that we've also had a patient that graduated high school, went off to college, during break needed some additional help, called in, and she got services while she was on school break, and then transferred back to college during the semester started. So, they're coming back to our community to get these services that you all helped us get started and continue to fund, so,
Thank you.
yeah.
Any other questions for? Are you going to talk about the?
I'll talk a little about the ED behavioral health area, just so everyone's aware. I know it's time.
That way you're closer to the microphone.
Okay. So what two learnings did our team in the last 6 months that we weren't expecting with the ED zone? Upon creating the behavioral health zone in the ED, we knew at times that we would need to convert that area to a medical triage space. Therefore, when we created it, we made garage doors. So for those of you, you know, they slide down and behind them is the oxygen machine, the suction containers, anything that are ligature risk, right? Well, throughout that time when we changed to the behavioral health area, and since we've rolled it out, we're noticing that the behavioral health zone wasn't fully, like there wasn't enough patients throughout the day there, right? You can't tell. At one point, we might have 4 patients in that area, and then a few hours later, we'd have nobody. So you'd go hours with nobody in that area, staff in the area, and patients waiting in the lobby, right, in the ED wanting to get back. So what we've done is we developed a plan of 1 to 2 behavioral health patients in the ED we can safely serve in room 1 and 2. Those are our psych rooms that we had before. But once we get 3 or more behavioral health patients, we change that area into the behavioral health zone. Now, that's just structurally right. The staff are still there. The patients still have access to the crisis specialist, the psychiatrist, the rapid behavioral health response, the whole crew. But we noticed to keep everybody happy, right, that we had to flex that room a little bit more than what we were expecting. The second thing was regarding the mental health stigma and the lack of knowledge around mental health and substance use disorders that continue to occur, not only in our community, but through our medical providers, our EMS, our law enforcement personnel. And a big part of this program was for our psychiatric crisis specialists to be able to provide education around those disorders. So we got together as a team, the crisis specialists, the RBR nurses, and Cleveland Clinic offers what's called a caregiver catalyst grant. So as a caregiver, if you see something that can improve the care of a patient or improve a process as a provider or a caregiver, you can write this grant, and it's up to $100,000. So our crisis specialists wrote this grant for mental health first aid. So mental health first aid for adults and youth. So we received that funding, and since that time, we have been able to train 9 facilitators in adult mental health first aid, and we have 1 facilitator for teen mental health currently. In addition to that, that'll provide us an opportunity to train around 450 of our Cleveland Clinic caregivers in mental health first aid, recognizing the signs and symptoms of mental health and connecting, as well as in partnership with the Mental Health Collaborative, teaching the community, right? Educating the community on those things.
It's a big commitment on their part. So
Yeah.
I was thinking, wait a minute.
It's really huge. And for those of you that don't, mental health first aid, it's about $28 for each participant. So as we go through this funding, we're also going to request an extension or some additional dollars, depending on how we go through with what the community wants with that. Some emerging issues that we've been seeing here locally, and I know it's kind of been discussed in some of our meetings, but we have seen an increase of patients being dropped off in the emergency department that are diagnosed with dementia and autism that have been placed under a Baker Act by a community professional. As you may or may not know, those are 2 disqualifiers to write a Baker Act on a patient, but the community doesn't have the resources to help provide care to those patients. So they're doing what they feel is the best, a Baker Act. So as we continue to plan forward and how we want to contribute to the community and improve, I think we need to invest time and energy around our services as it relates to patients with dementia, pushing forward and really advocating for less expensive skilled nursing facilities, assisted living facilities. You know, there's no family that wants to come and just drop their loved one off, right? You know, when they get to that point, they've really exhausted everything. And I don't know many people that can afford $6,000 to $10,000 a month for an assisted living facility. And then if you add a dementia or a mental health diagnosis, you're then in a locked unit, which 8,000 plus. So thinking what we can do in that area, as well as for not only our children that are diagnosed with autism, but also our adults. You know, we have seen, right now I have 3 adult patients on my unit right now that are diagnosed with autism, that have, the family has no services for them. It's challenging, you know, the closest one is almost 3 hours away. So, and as you know, one of the things that we've been working towards and where we see ourselves in the next 5 years is opening our medical detox unit there at the Behavioral Health Center, as well as expanding our outpatient behavioral health services. So we just wrote a grant, so say a blessing for us out there to try to get some money for expanding the outpatient, so.
That's great.
Yeah.
Excellent.
So.
Any questions?
I had a question. I always like the stories. You know, you picked the 3 best ones, I'm sure, to include, but the fact is, it tells a tale in a lot of different ways about what happens out of the norm. You know, when you can't just plug and play, what can we do for this
Right,
kid?
and it's
Or
such a
this adult.
blessing that we have those crisis specialists in the ED.
Yeah.
And since hiring them, it's been stable. I've got a wait, we talk about staffing, I have a wait list for therapists that want to be a crisis specialist, as well as work in outpatient and our inpatient center. Our psychiatrists that we have there on site at BHC, one's been there for 7 years, the psychiatric nurse practitioner has been there for 5, and our new medical director, he's been there about 1.5 years and plans to be there for a long time. So we're very stable as it relates to psychiatry in our programs. But you know, the one story where the young lady's, you know, walking up to the bridge, you know, and at that point wanting to take her life, and she remembers the experience that she had in our emergency department and at the behavioral health center. So everything going on in her mind, she still chose to pick up the phone and call and ask for help. So that
That's good.
speaks volumes. And though, I mean, I could go for days with stories that for both programs. But it's really great work that Kelly and her team does, the team at the Behavioral Health Center, you know.
I think one of the important things that you stated, you know, about persons being dropped off at the hospital, I think that's something that the community needs to start looking at as what I call the silver tsunami is happening.
Yes.
You're going to have more and more of that happening. And what are the resources out there? And there are some, but I believe that it needs to be just like we have mental health collaborative, I think that we need to have a discussion about, you know, aging up, autism aging up,
100%.
Developmentally disabled aging up, and
dementia.
seniors, and dementia, and Alzheimer's, all of those. And what do we do to support the families and the
you know,
persons?
I've worked a lot with the Department of Children and Families for children, right? Well, they have adult protective services, but I can tell you how many times I've spoken to them about they got called to a home for an elderly person that was going through something, that was hoarding. They had no place for the patient to go, so they call the police to Baker Act the patient, right? And then they come to the hospital. And I said, why would you do that? Well, it's safe for us to do that. To put an elderly patient that may or may not have any mental health issues in a psychiatric facility is not the best place for the patient.
No.
So as we continue to think about that, we have to invest time and energy in that.
And patients with dementia or Alzheimer's, you put them in that environment, I mean, that just exacerbates the whole situation, which is,
Absolutely, so,
there's always gaps.
Always.
no. So food for thought, I think that, you know, with our population that we serve overall through all our organizations, that is a struggle that we're experiencing.
Well, thank you for the good work you're doing.
Yeah, it was a good report, too. I mean,
Yes.
it's well-structured, there's lots of data there.
Thank you. Anytime, we're happy to give any data. Whatever you need.
Thank you.
Thank you for your support.
Thank you. Any unfinished business with trustees? New business, we have Robin.
Good afternoon.
Afternoon.
So on October 1st, the Senior Resource Association officially acquired 3 programs from the Senior Collaborative, which dissolved on September 30th. And those programs are the Upslide Program, Navigation, as well as the Senior Expo. So knowing that the hospital district had awarded $35,000 to the Senior Collaborative for the Upslide Program, Senior Resource Association respectfully requests that that money be transferred to Senior Resource Association to manage that program. Specifically, this transition was not foreseen when we did our budgeting back in the spring, so this would be a great help for us in managing it.
Any questions for Robin?
So it will be budgeted going forward so it wasn't budgeted, understand it wasn't budgeted. It'll be budgeted.
Yes.
Going forward.
Absolutely.
And so do you see it continuing to be a request to the district going forward? Do you have any?
We are going to
crystal ball on
continue
that?
to seek out other funding as the program grows, but it certainly is not out of the realm of possibility.
And the 35 was tied specifically to Upslide,
Correct.
not the Expo or
Correct.
the other services.
Just for Upslide.
Right.
Move approval.
So can I hear a motion for approval?
To approve?
Okay, you second, all in favor?
Aye.
Oh, okay, yes,
Great.
that's good.
Thank you so much for your support.
Any other business from trustees? Any public comment?
Yes, there is a gentleman on here. His name is Ray. He had a couple questions about Cleveland. I asked him if it would be okay if I give those to Frank. It's basically about virtual visits with a primary care doctor versus in-office visits, and he had some questions about that. It seems that they're transitioning more away from virtual visits, and he wanted to understand why there was a transition. And so I said we would give those comments to Frank to follow up with.
And then I will connect with the hospital and, yeah.
And for the record, his name is Ray Osborne, and I told him this would be in the minutes.
All right,
Okay.
thank you. Anything else from down there?
That's interesting.
All right, down there. Hearing none, we are adjourned for the month. Thank you.